now?
Sure.
So we are live.
So can we start? Okay. Maman, I think we will wait for our participants because of the delay. We are not. Are you letting in the people? So good evening and welcome to this international webinar in cardiology at Believers Church Medical College and Hospital. And to share his perspective and throw some light on stable ischemic heart disease, we have with us Senior Cardiology Fellow and Assistant Professor at the Department of Cardiology, Northeast Ohio Medical University, Ohio, USA, Dr. Karupaya Arunachalam. After completing medical school at PSG Institute of Medical Sciences and Research, India, he went on to train in internal medicine at Mount Auburn Hospital, Harvard Medical School, USA, and his postdoc fellowship at the Brown University. He's currently in his last year of fellowship, cardiac training in general cardiology at the Altman Hospital, Ohio. 20 publications in international peer-reviewed journals, close to a decade of student, resident, and intern training, and numerous awards to his credit, including the Travel Grant Award for EHRA, Cardiostem Conference, National ACP Awards, etc. He's a member of a number of prestigious societies like the American College of Cardiology, American Society of Echocardiography, and American College of Physicians. It's a great pleasure and honor to have you, Dr. Karupaya Arunachalam. Welcome to this webinar.
Thank you very much, Dr. Jacob.
And today's moderators are the champions of interventional cardiology at Believers Church Medical College and Hospital, Dr. Lena Thomas and Dr. Ravicharan Matthew. Dr. Lena Thomas is our consultant interventional cardiologist, expert in both adult and pediatric diagnostic and therapeutic procedures, recognized by the prestigious International Fellowship of the European Society of Cardiology, FESC, and elected fellow in the Society for Cardiovascular Angiography and Intervention, SCAI. Dr. Ravicharan Matthew is our consultant interventional cardiologist, a senior member with more than 1,000 angioplasties behind, trained by the doyen of cardiology in India, none other than Dr. K.M. Cherian, adept and experienced in all interventional cardiac procedures. He has been championing the cause for interventional cardiology in our hospital. So welcome Dr. Lena Thomas and Dr. Ravicharan Matthew to this international webinar.
Thank you.
And may I hand over the session to Dr. Lena Thomas to give an overview of the topic and hand over to our guest speaker, Dr. Karupaya. Over to you, Dr. Lena Thomas.
Yeah, good evening all. Am I audible?
Yes, ma'am.
Yeah, as we all know, the coronary artery disease can have a long stable periods. Then we call it as a chronic stable disease, but it can become very unstable at any time. So typically, this is due to an atherothrombotic event, which is caused by a plaque erosion or rupture. So the disease is chronic, but often progressive, even in clinically apparent silent periods. So this dynamic nature of the disease process results in various clinical presentations, which can be collectively called as, the new name is a chronic coronary syndrome, So it is rather unstable actually. Even the chronic coronary syndrome, the name itself shows that it is a chronic progressive disease. So this atherosclerotic process can be modified by lifestyle modification, pharmacological therapy. So may I invite the presenter, Dr. Karappaya Arunachalam, to begin the presentation.
Thank you very much, Dr. Lena. Thank you, Dr. Jacob. It was a great pleasure and an honor to present in front of all of you. Thank you very much for the opportunity. So the reason I chose this topic is that most of the times acute coronary syndrome takes the lead, and everyone concentrates more on acute coronary syndrome. But there was a trial recently by name Ischemia trial, which got published this year, which focused more on stable ischemic heart disease. And there was also a controversy because in olden days, they used to stent whenever they see critical blockages in the coronary arteries. So that's when there's a lot of trials, and the main trial recently got published was ischemia trial, where they decided to see if medical management is equivalent or better than the invasive strategy like stenting and bypass surgeries. So as the audience is mostly undergraduates, I'll focus more on pathophysiology and basic pharmacology of all the medications and medical therapy. But also we will focus on the diagnostic approaches, the role of imaging in stable ischemic heart disease, also some of the recent trials, which are landmark trials, and soon it will be included in most of the guidelines. As far as I know, the recent guideline was from 2012 by ACC-AHA. That's what we have been following. But all these trials, which I'll be discussing towards the end, will be focusing more on updated therapies for the stable ischemic heart disease. So let's start with the presentation. So as Dr. Lena described, there are various ways you can call stable ischemic heart disease. You can say stable angina, chronic CAD. Sometimes you can call asymptomatic coronary artery disease if they're not having symptoms for a long time, and incidentally you find they have blockages. And also when someone comes into the heart attack and after revascularization, which is basically stenting or bypass surgery, they enter into a phase called post-revascularization CAD, which is also part of stable ischemic heart disease. Next slide, please. And again, so there is various ways you can call it. Recently, they decided to do more clear way to name the disease. So ischemic heart disease is like an entire spectrum. Ischemia is basically lack of blood supply. The patients can present with two different presentations. One is acute coronary syndrome, which is more familiar. A lot of people know it because it leads to sudden death and so forth. So acute coronary syndrome is basically someone presenting acutely with chest pain, and you found them in state of MI. So which is ST elevation MI and non-ST elevation MI, and something is called MINOCA, which is myocardial infarction without any evidence of obstructive coronary artery disease. The belief is that there is a microvascular disease in the myocardium leading to myocardial infarction. The stable coronary syndrome is, as we spoke, stable ischemic heart disease, which is usually due to obstructive CAD, but you also have something called ischemia without obstructive coronary artery disease. That's called INOCA. That's also similar to microvascular disease or microvascular angina or small vessel disease, which is not evident clearly on cardiac catheterization. And the next slide. So let's look at the spectrum of ischemic heart disease. So at one point of time, everybody is asymptomatic and they don't have any history of ischemic heart disease. So they enter into the spectrum clinically only when they have symptoms. So most of them, or at least 50% of them, will have chest pain. So when they have chest pain, they either present as acute coronary syndrome, which is ST elevation myocardial infarction, non-ST elevation myocardial infarction, or unstable angina, or they can still continue to be asymptomatic. And on the other side, they can present with stable angina, which is basically having chest pains predictably with exertion, resolve with rest, and they continue to stay that way without going to the phase of acute coronary syndrome. But a lot of times they can have acute coronary syndrome, or sometimes they can present with heart failure, and sometimes people remain asymptomatic, and you find it incidentally during other workup or during surgeries, and also they can present with sudden cardiac death. So these are the spectrum of ischemic heart disease. And next slide. Now, briefly about the progression. It's again a little bit of reiterating the same facts. So the entire spectrum is called atherosclerotic cardiovascular disease, and you can present as stable ischemic heart disease or acute coronary syndrome. And the other term they use is ischemic cardiomyopathy. What is ischemic cardiomyopathy? Someone who has acute coronary syndrome develops a complete transmural infarction. They can have systolic dysfunction or heart failure, and they continue to have symptoms of heart failure. And if the etiology is ischemia, then you can call it ischemic cardiomyopathy. And so patients both with stable ischemic heart disease and acute coronary syndrome, eventually they can have something called refractory angina, where they have a lot of chest pain and ongoing chest pain, but without any evidence of further myocardial infarction or heart attack. Those are the patients in which it's very difficult to manage, especially the symptom control, and further revascularization may not be an option for them. Next slide, please. So how do you distinguish stable ischemic heart disease from acute coronary syndrome? So when someone has worsening symptoms like worsening chest pain, worsening shortness of breath, and the pain duration is more than 20 minutes, and you have EKG changes, which is basically ST elevations or ST depression, T-wave inversion, and new left bundle branch block. And further, when you do blood work, you can find elevated troponin. Serum troponins are more specific and sensitive for myocardial infarction. If they have those features, then you say it's acute coronary syndrome, which is more acute, and you need to act early in those patients. So that distinguishes us from acute coronary syndrome from stable ischemic heart disease. Next slide, please. I'm not sure that you're able to see. This is a classic picture from, I think, from Robbins pathology that shows pictorially how the plaque develops. So initially, everyone has a fixed coronary obstruction that, as we spoke, it presents as stable ischemic heart disease, or they remain asymptomatic depending on their functional status. So the plaque is rich with lipids and fibrous tissue, and so you can see the outer layer is called tunica adventitia, the middle layer is tunica media, and the inner layer is the tunica intima, which is lined by endothelial cells. So when the plaque builds up, the macrophages engulf all these lipids and they form the plaque, and it starts engulfing into the lumen. That's how it narrows down the lumen. And someone who is very active, does exercise every day, will be able to find out if they are developing symptoms like chest pain or shortness of breath, and sometimes they can have worsening symptoms. So from that stage of fixed coronary obstruction where they present with typical angina, the next stage, either they stay that way developing chronic heart disease, or sometimes due to stress, emotion, and sometimes like shear stress leads to plaque rupture. That's when your the endothelium gets exposed, and you von Willebrand factor and collagen get exposed, which activates the platelets, and the platelet aggregates, and then thrombus formation starts. When there is like partial thrombus formation, you develop unstable angina or non-ST elevation MI. When the thrombus completely occludes the vessel, you develop something called STEMI or ST elevation MI, which leads to complete transmural myocardial infarction. Next slide, please. So the next slide again explains the whole pathophysiology from the normal blood vessel, how it looks, and when they start developing fatty streaks, and which becomes plaque, and then the plaque gets worsened, and at one point the plaque becomes unstable. That's the term we use when the plaque becomes unstable and ruptured. They develop acute coronary syndrome or NSTEMI. Next slide, please. So subclinical and clinically, what happens to the heart when they have coronary obstruction? This is one of the most important pathophysiology one should understand. Initially, they will have subendocardial perfusion due to vascular dysfunction. Patients, mostly they don't feel symptoms, and they start feeling symptoms when they go into altered metabolism, when there's a lot of lactic acidosis because of ischemia and hypoxia. And diastolic dysfunction was the first clinically evident picture that we are able to see, because when they do an echocardiogram, mainly the stress echocardiography, you will see like you'll be able to find diastolic dysfunction and also wall motion abnormalities when they have more obstruction of the coronary blood vessels. And eventually systolic dysfunction happens when the coronary obstruction persists. There'll be a drop in pumping function of the heart, or the systolic function, which we call global systolic dysfunction. The last stage will be the EKG changes. That's when the patient presents to the doctor or the emergency room with active chest pain, and you see EKG changes. That's one of the last changes that happens with coronary artery disease or coronary artery obstruction. And basically, the ischemia is the increasing oxygen demand occurs in the heart, but there is a decrease in oxygen supply. So there is a demand supply mismatch due to an obstructive disease in the coronary blood vessels. Next slide, please. So as we discussed, the etiologies are atherosclerosis, which is the most common majority of the population. Then it's principal angina, which is vasospastic angina, and endothelial dysfunction, which is basically microvascular disease. And least etiology would be coronary anomalies. Sometimes you have malignant cores of coronary arteries. The left coronary artery will be originating from the right side and then gets compressed between the great vessels during exercise. They can have sudden death, they can have exertional symptoms. A lot of young people might face sudden cardiac arrest because of malignant cores of coronary arteries. But it's very rare, maybe seen in Western world. Next slide, please. So what are the symptoms of stable ischemic heart disease? It's usually predictable angina. Patients will come to you with chest pain whenever they are exercising or whenever they are active on exertion, usually lasting like 5 minutes, and they notice the chest pain and they decide to take rest, and then it resolves with rest. So it's all predictable. Chest pain with exertion, resolving with rest, lasting only a few minutes. These are the symptoms of stable ischemic heart disease. And as we spoke before, when the chest pain is lasting more than 20 minutes, or if it's getting worse and they're having progressively worsening symptoms, then you worry about acute coronary syndrome. next slide, please. So what is a typical angina, which as a medical student, the people should know is there are 3 specific criteria to call someone is having a typical angina. If it is substernal or left-sided chest pain, and then it has to be having some trigger factors like either emotional stress or which reproduces every time on exertion. That's the triggering factor, and has to have some relieving factor like the chest pain resolving with rest or nitroglycerin. So those are the factors. So if someone meets 3 criteria of chest pain, then you call it typical angina. When someone has only 2 of these criteria, you can call atypical, and you call non-cardiac chest pain if they don't have any of these criteria or just have 1, which is most of the case. We see like people just have chest pain, they don't have other symptoms, but it's very hard to rule out until, especially if they have like a lot of risk factors like diabetes and age and family history. So next slide, please. So when you diagnose someone with stable ischemic heart disease, the foremost step is always risk modification, like dietary changes, low fat, low cholesterol diet, low sodium diet, which is usually 2 grams in a day, and then weight reduction, smoking cessation. Data-wise, they say when you stop smoking for 5 to 10 years, you can reverse your risk of getting a heart attack. That's the general ballpark number based on some observational data. And your lung disease reverses after you stop smoking for like 15 to 20 years, which is a long period of time. And exercise is one of the other important therapy or risk modification when someone has stable ischemic heart disease. It can worsen the symptoms, but when you're on an appropriate medication or after revascularization, exercise is extremely important in patients with ischemic heart disease. Next slide, please. So coming to the management, there are 3 levels of management or 3 arms. One is medications, PCI, and CABG, or coronary artery bypass surgery. We will be focusing more on medications, and then we will focus on the new trial which got published, PCI, regarding PCI and medications, the ischemia trial. So first we will focus on the medications. Next slide, please. So as you all know, aspirin is the cornerstone treatment strategy for ischemic heart disease. So the dosage differs in different countries. In India, I think when I was a student, we used 75 milligrams of aspirin. In US, it's 81 milligrams. And so that's the main treatment. The next one is statins, which is a cholesterol lowering medication, mainly LDL. Then the nitrates, when someone has lots of chest pain and symptomatic improvement, relies on nitrate treatment, which is usually sublingual nitro in an acute setting, or you use a long-acting one like isosorbate mononitrate. The other anti-anginal therapy is beta blockers, which we will discuss more in subsequent slides. And the last one, last but not least, is the ranolazine, which is recent, like approved in 2006. It's mainly a metabolic modulator. It doesn't have anything to do with the heart rate or the inotropy of the heart, but it blocks the sodium channel, by which it decreases the anginal episodes. So we will go one by one based on the evidence-based medicine, basically. So next slide, please. So the antiplatelets, mainly the aspirin. So everybody knows that to give aspirin when someone has chest pain or heart disease, but how did they come up with? How do they know that aspirin is effective? So based on like the observational data and a lot of trials in the past, so based on the meta-analysis from 174 trials, like aspirin is one of the main antiplatelet agent, which helps in preventing future cardiovascular events, including myocardial infarction. As we spoke earlier, aspirin 75 to 81 milligrams. In some countries they use 100 milligrams, which is low dose aspirin. Basically, aspirin inhibits cyclooxygenase 1 pathway, inhibits the production of thromboxane A2, which is a platelet activating factor, which initiates platelet aggregation. So now the clinical question is, what someone is allergic to aspirin, or someone is intolerant to aspirin? People may have GI bleeding. Some even may have like angioedema or severe allergic reactions. How do you treat those patients? So you can do monotherapy with clopidogrel, which is called Plavix. So if they are intolerant to aspirin, you can do Plavix 75 milligrams daily to prevent and treat the heart disease in case if they are intolerant to aspirin. So how did they come up with that? Based on the two trials, Capri trial and Charisma trial. So Capri trial is just based on the randomized two groups, one group to clopidogrel monotherapy and another group to aspirin. Actually, in that trial, they found clopidogrel monotherapy is better than aspirin monotherapy. And in the Charisma trial, they used dual antiplatelet agents, which is aspirin and clopidogrel. And they compared to aspirin. They found the combination of dual antiplatelets, aspirin and Plavix, was better than aspirin. But obviously, there was more bleeding symptoms and episodes in that group which used dual antiplatelet agents. So next slide, please. So the next therapy is statins, which is basically HMG-CoA inhibitors. Routinely we use simvastatin, atorvastatin, and rosuvastatin. They inhibit this HMG-CoA enzyme, which prevents the final formation of cholesterol. By that it lowers the LDL level. So statin is one of the most important, or the most important, along with aspirin, in preventing major cardiac events. It reduces by 30% of future heart attacks and sudden cardiac death and stuff like that. How does it do? Not just by reducing the LDL cholesterol levels, it also regulates the nitric oxide synthase, by which nitric oxide is produced, which is a vasodilator, also inhibits platelets, decreases free radicals, which are like negative ions that can cause a lot of endothelial injury, and also eventually it stabilizes the plaque by that mechanism. Next slide, please. So the recent guideline from 2018, so what they say is the goal LDL for patients with diabetes, history of MI or coronary artery disease or peripheral artery disease, the goal LDL is less than 70 milligram per deciliter. So you'll have to choose a statin drug which is of moderate or high intensity that reduces the LDL to less than 70 milligram per deciliter. And also the goal should be to reduce the LDL levels by 50% from the point where they started. Next slide, please. So now it's a question to the audience. I don't know whether they can answer or text, but the thing is, so it's a case which will be of some interest. So 70-year-old male with recent non-ST elevation MI had a drug-eluting stent placed to left anterior descending artery. So he presents to the cardiologist office or the clinic for follow-up. He complains of severe muscle pain. So the cardiologist decides to get the blood test CPK, and the CPK, creatine phosphokinase, is elevated. So what should the cardiologist do next if he's having severe muscle pain with the statins? Yeah, you can
I think
text your question.
I think the students or other delegates will post their answer in the chat.
Okay, that sounds good.
Yeah. Let's wait for them to reply. Dear friends, you can post your answer in the chat box. We're waiting for your answers.
That's good. Someone answered, stop the drug first. That's correct. So when someone has evidence of myositis, which is basically elevation of CPK, creatine phosphokinase, that's Dr. Shiba. Thank you so much. So someone complains of muscle pain. If it's mild, you can try to cut back on the drug, or you can switch to a lower intensity statins, which is usually like lovastatin, fluvastatin, or low dose simvastatin. So basically, atorvastatin and rosuvastatin is called as high intensity statin. So when you can like downgrade the intensity of statin and see if their muscle pain goes away. But if they have severe muscle pain, severe symptoms of myopathy or weakness, then I think we are bound to check lab to see if there is any evidence of muscle damage. If they have elevated CPK, then there is myositis. So it's an indication to stop, or absolutely contraindicated to give the statins. So what would you do next? This guy had a MI, and so he's having myositis, and you stop the statin. Now you have to reduce his risk to prevent his future heart attacks and major cardiac events. So how are we going to reduce that? Let's see from shortly from next slides. Next slide, please. Yeah, the answer is PCSK9 inhibitors. I'm not sure whether this is of interest in India or if they are using it now, because I'm not currently practicing for last 8 years there. So PCSK9 inhibitor is basically, there's a PCSK9 protein, as you can see in the image. What it does is it participates, or its main function is to destroy or downregulate the LDL receptors. So the LDL receptor gets engulfed into the cell using this PCSK9 protein and then gets destroyed. So LDL receptors are the ones which removes the LDL, the bad cholesterol, from your blood. So if these receptors are getting destroyed, more LDL will be circulating. So the PCSK9 inhibitors basically binds to this PCSK9 protein and prevents from destroying all these LDL receptors. So there will be more LDL receptors, as you see on the right side, hanging out in the cell in the liver. So what happens is it binds to more LDL in the blood or serum and then gets metabolized. So your LDL level in the blood will be like severely low. So in that way, they're trying to see whether it reduces the risk of future major cardiac events. So let's look at some of the trials where they use PCSK9 inhibitors, which are fairly recent, published in last 2-3 years. Next slide, please. The first one was the Fourier trial. Fourier actually stands for further outcomes of cardiovascular events. So basically let me pull up my little cheat sheet. So basically they were trying to see if PCSK9 had any impact, or what was the impact on LDL levels after they started on these PCSK9 inhibitors when they're already maximized on their statin therapy. So these patients are already on statins, like moderate or high intensity statins. So the first curve, what you see is the control population where nearly 13,000 patients in each arm. So first curve is where they use placebo with patients who are already maximized on statin therapy. And the second curve you see is a arm where they used evolocumab drug, which is brand name is Repatha, along with the maximized statin therapy. So the patient population is mainly who has high risk factors for CAD or has had history of CAD or stroke or peripheral arterial disease, who are on statin therapy, but the clinician is not able to get their LDL level below 70. So they use this PCSK9 inhibitor, which is evolocumab is basically a monoclonal antibody that attaches to the PCSK9 and prevents its destruction of LDL. So it's an injectable drug, subcutaneous injection you give every 2 weeks. So in each arm, there were nearly 13,000 patients. So they saw what was the LDL level before and after treatment with evolocumab when they compared to placebo. So as you can see, within like a couple of months, there was like increased reduction of LDL. There's almost drop of more than 50% of LDL levels after starting treatment with evolocumab. And so that's the mean LDL reduction you can see. It's a huge drop. So clinically what we see is the mean LDL levels were somewhere around 30s to 50s when they are on this PCSK9 inhibitors. Whereas with statins, sometimes you're able to get below 70, sometimes it's the patient's LDL level runs from 70 to 100. So this drug played a great role in reduction of LDL. And next slide, please. So this is the outcome based Kaplan-Meier curve showing what was the difference in the outcome based on using placebo versus evolocumab in preventing cardiovascular death, MI, stroke, and unstable angina. So if you see, the reduction is just like 1.5%. It's not a lot, but because the patient population and the power is so high, it was statistically shown to be significant. But if you see the drop in the death rate or the event rate, it's like 9.8% in evolocumab arm, whereas it was 11.3%. So that's the difference at 18 months, if you can see. Next slide, please. Similar to it, there was another, like a competing drug company, which had a different trial called Odyssey trial, where they used alirocumab. So alirocumab is basically another monoclonal antibody that attaches to the PCSK9 protein. So this trial is different in the sense that they enroll patients with acute coronary syndrome. So they used a different concentration of or the different dosages of alirocumab. That's why you see two different curves in alirocumab. So as you can see, compared to placebo, the amount of LDL reduction was significantly better in patients with alirocumab compared to placebo. So the mean level is somewhere from 40s to 60s in alirocumab arm, whereas the LDL level is like 90s to 100s in placebo arm. Next slide, please. And this is the Kaplan-Meier curve for incidence of cardiovascular events. And you can see the significant difference between the placebo and alirocumab arm. The relative risk reduction was 15%, and the number of events or event rate is 9.5% in patients with alirocumab and 11.1% in patients who used placebo. The number of patients enrolled in this trial was 9,000 in each group. So this is the one study with PCSK9 inhibitor where they tried to show all-cause mortality was better with PCSK9 inhibitors. It's statistically significant, but the difference in the percentages is not that great, like 3.5% all-cause mortality in patients who used alirocumab, whereas in placebo, it was like 4.1%. Next slide, please. This is another fairly recent trial called Reduce It trial. This in this trial, the main key feature is like if there are cardiologists or cardiology postgraduates, this might be of interest. They used a drug called icosapent ethyl. The brand name is Vasipa, and this was published like 2 years ago. This is called Reduce It trial. The main patient population is like patients with hypertriglyceridemia. So they enroll patients with coronary artery disease and other vascular disease, and they enroll nearly 4,000 patients who are on statin therapy or maximized on statin therapy, either to this experimental drug icosapent ethyl or placebo, and they tried to see what was the difference. In this study, it was like very smartly done. They showed like a great reduction in primary outcomes. So the primary outcomes were mainly MI, cardiovascular death, stroke, and unstable angina. In this patient group, the primary outcome was 17.2% versus 22% in placebo. So the follow-up was for nearly like 4 to 5 years. So now these drugs might be included in the future guidelines, and they might be part of our treatment strategy for this patients population with stable ischemic heart disease. So not just statin, on top of statin, if their LDL is not controlled, you can initiate these PCSK9 inhibitors, or if their triglycerides are high, you can initiate Vasipa or icosapent ethyl drug to reduce their triglyceride levels and reduce the future cardiovascular events. So yeah, next slide, please. So we discussed about aspirin, statins, and the role of PCSK9 inhibitors and the newer drug icosapent ethyl. So after these drugs, the stable ischemic heart disease, the other main issue for them is the angina, the frequent chest pain episodes. So how do you get rid of the chest pain? For the symptomatic improvement, nitrates are the main therapy for symptomatic improvement from angina episodes. So how do they act? They reduce the workload, cardiac workload, by reducing preload and also afterload. And they also cause vasodilation of the epicardial vessels, and they also have some weak inhibition of the platelets aggregation. So mainly to alleviate symptoms and increase exercise tolerance. Trials have shown no survival benefit. It's mainly for improving their quality of life and reducing the symptoms. Next slide, please. So now another question, if people are around. 63-year-old male with history of coronary artery disease and history of stents, maintained on medical therapy with aspirin, atorvastatin, or isosorbate mononitrate, atenolol, sees the family doctor and requests prescription for Viagra, which is sildenafil, for erectile dysfunction. So what should the family doctor do? This is just a question which helps in your clinical practice. Also, it can come in your exams. So when someone is on these drugs, like aspirin, statins, isosorbate mononitrate, atenolol, the patient is requesting for Viagra or sildenafil, should the family doctor prescribe, or what should he say? You can post your answers just like what you guys did earlier. Yeah, that's great. So Amala and Meda, they answered correctly. So, but the concept is correct, but you don't stop the isosorbate mononitrate until the patient wants to. Really badly wants sildenafil, then you can stop isosorbate. But what I would do is I will not prescribe sildenafil or Viagra. Explain what are the risks and what are the possibilities with taking both the drugs, mainly like hypotension and sudden death, as someone posted. So in this patient, if isosorbate mononitrate is very important, like if he has been having chest pain and it was difficult to control, then isosorbate mononitrate is the most important treatment for this patient. So you won't stop the isosorbate. You tell them that just politely that the Viagra is not indicated right now, or it may cause serious side effects. So it's absolutely contraindicated to prescribe Viagra when someone is on isosorbate mononitrate. But as someone pointed out, if they badly want Viagra but they don't want to take isosorbate anymore because they are not having any chest pain, you can have a trial to stop the isosorbate mononitrate, which is half-life is like 1 to 2 days, mostly like 1 day. That's a 1 day drug, so you can stop the isosorbate. So that's correct. Good. So let's move to the next slide. And beta blockers. So that's the next another important anti-anginal drug. And the main thing about beta blocker is it has shown survival benefit. So we clearly discussed before that the nitrates doesn't have survival benefit. It just has symptom improvement and it improves the quality of life. But beta blockers has survival benefit. How does it have survival benefit? It reduces arrhythmias. It improves the diastolic function. It improves the relaxation of the heart muscle, reduces the cardiac workload and oxygen demand. This is one drug which reduces the oxygen demand and reduces the cardiac workload better than nitrates by improving the relaxation and reducing the tachycardic episodes. Next slide, please. So it improves mortality. The major drugs that are important are carvedilol, metoprolol, succinate, and atenolol. So in those trials where they found out beta blockers are beneficial for survival in acute coronary syndrome or post-MI patients, were using these drugs, whereas metoprolol tartrate or non-selective beta blockers are not shown to have any benefit of survival or improved outcomes. And as we know, beta blockers are not for vasospastic angina because it can have a negative effect because of negative inotropy. A mainstay of therapy for vasospastic angina is calcium channel blockers. So in my experience, we use a lot of cardioselective beta blockers like metoprolol succinate successfully in patients with COPD asthma, but you can't use like propranolol or a non-selective beta blocker. But literature says like, oh, you have to be cautious with patients with COPD asthma when you use a cardioselective beta blocker. And one interesting point about nebivolol, which is a cardioselective beta blocker, is that it induces nitric oxide synthesis in endothelium, by which it causes vasodilation and also has an endothelium protective effect. And the reason I put lipid abnormalities with a question is there are like controversial data on beta blockers that it can cause lipid abnormalities. Mainly it elevates LDL, reduces HDL, things like that, but it's not proven yet, or that shouldn't preclude from prescribing beta blockers. Next slide, please. and more info. So the stable ischemic heart disease, if they are after an MI or kind of unstable angina or high risk features, beta blockers have shown to benefit. But if someone is having an asymptomatic CAD with a good systolic function, or who has been having stable ischemic heart disease from the very first time when he was diagnosed with coronary artery disease, beta blockers have not a good data to support its use in patients with those specific population, because it's mainly shown benefit in patients who have had MI or has history of MI, and with people with systolic dysfunction or pump dysfunction. Then the question I asked myself was like, how long do you continue beta blockers after acute coronary syndrome or after a myocardial infarction episode? Yeah, we can have a minute. So if people can answer, they can answer. Yeah, that's what I thought too. Someone said lifelong. Yeah, that's what I was thinking. Like lifelong, you do beta blockers, because that's what I see routinely. Like patients are on beta blockers for like 15 years, 20 years. Like they are on taking metoprolol forever. But then actually, it's not true. They have shown to benefit only people with for like short period of time, like 3 years. So I tried to look it up, and actually the AHA or ACC guidelines, they say beta blockers are class 1 indication up for only up to 3 years. So you can elect to stop beta blockers if after 3 years, if they want to cut down on their drugs and medications. So remember 3 years. Okay. Next slide, please. So the data and importance of AC inhibitors and angiotensin receptor blockers in mainly patients with stable ischemic heart disease. There were like 3 trials I could find out. The 2 trials showed significant benefit in patients with stable CAD and preserved heart function without systolic heart failure, like especially ramipril and perindopril. These patients had good outcomes and better prevention of cardiovascular events. The one trial which did not show any benefit was PEACE trial using trandalopril. So maybe you can consider using ramipril on your patients with stable CAD, especially when they have hypertension or diabetes or chronic kidney disease. I think the way it helps or prevent the cardiovascular event is that it promotes LV remodeling and reduces blood pressure, reduces the angiotensin, renin-angiotensin mechanism, which can have a lot of negative remodeling effects in the heart and the blood vessels. Next slide, please. And the final drug I just want to discuss is ranolazine. So ranolazine comes into picture when you have difficulty controlling their symptoms, especially patients with refractory angina. So they don't have evidence of heart attack, but they keep having chest pain. You started like nitrates, beta blockers, maximized on them, but they are still having symptoms. What do? You can start ranolazine, which is the brand name is Ranexa. It's approved in 2006, as I told before. So it doesn't have any direct effect on the heart rate or the muscle contractility or diastolic function. The main action is it inhibits the sodium current during the depolarization process, which leads to calcium overload in myocytes and increases the ATP reserve. Probably leads to good contractility, but there is no good evidence or proper identification of mechanism how it improves the angina. But there are like 3 randomized trials which showed significant improvement in anginal frequency with using the Ranexa. The starting dose of Ranexa, ranolazine, is 500 milligrams twice a day, and you can go up to 1,000 milligrams twice a day. It's an expensive drug, and it has shown to improve the frequency of anginal episodes. And the one thing to remember about ranolazine, which can come in your exams, is that it can prolong QT. It has never shown to have any effect on uh, uh, leading to torsade or a polymorphic ventricular tachycardia, but it has shown to prolong QT. So that's one thing to remember for your exams or clinical practice. Next slide, please. It's a sort of a crowded slide, but I hope you guys can see. So basically, I just want to concentrate on the colors. The green colors is like a class 1 indication, and the yellow color is like class 2 indication. So what it mainly, in this slide, what we are going to talk about is the approach of stable ischemic heart disease. How do you diagnose them? Due to the time, I think I'll just explain it in a simple way. So whenever a patient comes, so you take the history exam, do EKG, and then you try to classify whether they have a high risk clinically or a low risk. If they are having high risk symptoms like unstable angina, you send them to the emergency room and check the blood work, make sure they are not having a heart attack. Even if they are not having a heart attack, they are having a lot of worsening symptoms. The best strategy is for invasive cardiovascular strategy, invasive coronary angiogram, and if stent if needed. So if they are having low risk features or very predictable symptoms, chest pain lasting less than 5 minutes, no EKG changes, like lasting for months and weeks, you don't have to rush them to the cath lab or send them to the ER. So what you can do is get a EKG, and if the EKG is readable and if they can do exercise, you can get an exercise stress test. So what kind of imaging you choose? So stress test, you can do it in just without plain stress test using Bruce protocol, which is called exercise EKG stress test. And then you do, if someone has a risk factors or high pretest probability, you do exercise stress test with imaging, mainly like nuclear cardiac imaging or echocardiography stress test. And then based on that, you classify whether they have high risk CAD or they don't have CAD. If they don't have diagnosable ischemia or angina on the stress test, well and good, you don't have to pursue anything further. But if you see like a very high risk feature on these stress test imaging tests, you will have to recommend them to undergo coronary angiogram to see if they are having any high risk blockages or if they need a bypass surgery and things like that. So what else can you do if they are not candidates for a stress test, or the stress test is equivocal or not helping you in making a decision? You can do coronary CTA. As I told you before during the beginning of the talk, coronary CTA is like it's like getting more refined. Back in olden days, the machines were not old and the images were not that good enough to diagnose or call any coronary blockages. But now there is like a lot of new high definition CTs which can identify blockages more than 50% precisely. And that's what they used in this ischemia trial. And also you can use cardiac MR where you can find out whether there is any wall motion abnormality or late gadolinium enhancement and things like that. So next slide, please. So the diagnostic approach, this is somewhat a better slide. Again, the green ones are the class 1. Class 1 is, we know that it's highly indicated based on randomized trials. The evidence is strong. That's what it means, class 1 is. The yellow is class 2. The evidence is not that strong, but it's still indicated to perform these tests. So the first, when we go down the algorithm, so known ischemic heart disease, if the patient is able to do exercise and the EKG is interpretable, you go to your right side, you can do exercise stress or pharmacological stress with imaging like echo or nuclear imaging. And the pharmacological stress, cardiac MR is class 2 in that patients. If patient is not able to exercise, what do? You can do pharmacological stress test using reg adenosine or adenosine. then you can do coronary CTA. I'm not sure whether the undergraduates are exposed to the stress tests and coronary CTAs yet, but I think it's better to know briefly, and then you guys will encounter this if you're going into the stream of medicine and cardiology later. So down, if they have a left bundle branch block on EKG, then you have to do some sort of imaging along with the stress test, which is nuclear cardiac imaging or an echocardiogram, to see if there is any diagnosable ischemia. And if, as I told you before, in using the imaging, if you see if there is a high risk CAD, then you recommend them to have a cardiac catheterization. That's the take home point. So that's the whole thing about the stable ischemic heart disease. Though they have stable symptoms, but on the imaging, if they have high risk features, which is more than 10% risk of death and stuff like that, then you recommend them to have coronary angiogram. But if the stress test is equivocal and or on the coronary CTA, you think the blockages are less than 50%, then you can stabilize them with medicines. You don't have to subject them to angiogram or cardiac catheterization. Next slide, please. So what is high risk CAD? So it's more than 3% annual death or MI. So what are the high risk features on the imaging? When you do a stress test, you get imaging, the nuclear cardiac imaging or echocardiography. On echo, if you see the ejection fraction or the systolic function is less than 35%, that's not good. It's a high risk feature. Or on the nuclear imaging, if more than 10% of the myocardium is involved, then you say it's a high risk CAD. And if the patient is dropping the blood pressure during the stress test, or if they are having dilated left ventricle during the stress test, or if there are more than 2 segments of myocardial segment is involved, then you say it's a high risk CAD. And then if you suspect multi-vessel coronary artery disease, like involving all the 3 vessels, or the ostium or the proximal LAD or the left main is involved, then you suspect high risk CAD. So you send these patients to coronary angiogram. Do not take a risk, because these patients are at high risk for like increased cardiac events in next 30 days. So you can't attempt medical therapy and wait for them to improve like the usual stable ischemic heart disease. Next slide, please. This is just the overview of the medical therapy for stable ischemic heart disease, which we went through. As I told you before, the green colored boxes are class 1 indications, and the the yellow boxes are class 2. So when you diagnose someone with stable ischemic heart disease, if they're having anginal symptoms, you give sublingual nitroglycerin. Then you start them on beta blocker if there is no contraindications. If there is a contraindications like severe asthma or COPD, you replace them with calcium channel blockers or long-acting nitrates. When you go down the line, and then on the left side, you focus on lifestyle modification, smoking cessation, dietary changes, and you prescribe low dose aspirin, 75 to 162 milligrams. You do moderate to high dose statins. These are all like absolute therapy for stable ischemic heart disease. And if you're not able to achieve LDL goal with moderate to high intensity statin, you can add PCSK9 inhibitors, as we discussed earlier. And if they are intolerant to aspirin, you can give them clopidogrel 75 milligram daily as a monotherapy. But always there is some high risk of GI bleeding and bleeding issues in those patients. And last resort for refractory angina is ranolazine. And even with ranolazine, if they're having a lot of chest pain symptoms and not able to control, then it's ideal to proceed with coronary angiogram and revascularization. And there is one more thing which I don't think I included, which is called external counterpulsation, That's for patients who have refractory angina, but they're also not a candidate for revascularization. So that's kind of an outpatient therapy. Next slide, please. Next slide, please. Yeah. So we discussed so far about medicines, medical therapy. So briefly, I'll finish up my talk with the invasive, like what are the strategies in invasive therapy, or like stenting and revascularization and all that. So in stable ischemic heart disease, how did they come up with medical management is equivalent or non-inferior to placing a stent by doing a coronary angiogram? Based on these trials, which you should know, the most important one is the Courage trial, which was published in 2007. That is, like, every research has its own limitations and problems. It's like you have to take it with a pinch of salt, because this Courage trial was done in patients when in 2007. It's using the bare metal stent. Nowadays there are like a lot of higher end stents, but this was done using a bare metal stent which doesn't have any drug eluting nature. But bottom line, they randomized 2,000 patients, 1,000 patients in each arm. They trialed and saw whether medical therapy is better or doing an angiogram and placing a stent is better in patients who are having stable symptoms. They didn't see any significant difference on 5-year follow-up. The risk, I can give you numbers: 19% in patients who got stents and 18.5% in patients who had medical therapy, which is the primary outcome, like all-cause mortality, non-fatal MI, unstable angina, things like that. So the incidence of these events were pretty much same in both the groups. The next trial, Barry 2D trial, was done in diabetic patients with CAD, stable CAD. They were followed up for 5.3 years. One group had like 1,000 patients, another group had 1,000 patients. Of these 1,000 patients, they went for stenting and bypass surgery. The other 1,000 patients were medically managed and they were followed for 5 years. The survival was pretty much same, 88.3% and 87.8% in both the groups. The next trial, which was contradicting the above two trials, FAME2 trial, in this trial, what they did different was they randomized 1,000 patients to two groups. One group, they just didn't do the heart cath and stents. What they did was something called FFR, and they stented patients who were FFR positive. FFR is basically fractional flow reserve. Cardiologists know it very well. So the cutoff number is 0.8. So they do this test in the cath lab. If the value is less than 0.8, it's called like a flow limiting lesion or a significant lesion. So they go ahead and stent it. So they saw that in this group, when they did an FFR and stenting, the urgent revascularization and an acute event was 1.6%, whereas the medically managed patients, the event rate and the urgent revascularization was like 11%. So, which was a pretty significant difference. And that's how the FFR during the coronary angiogram became famous, and it's highly indicated to perform when someone is doing a coronary angiogram and stenting. I think we are nearing the end of the talk. So the ischemia trial, this was like a talk of the year and published in I think June or April 2020 in New England Journal of Medicine. This is one of the largest trial to see if medical management is equivalent to or better than angiogram and stenting. So they initially evaluated 35,000 patients, and they finally ended up enrolling like 3,000 patients. But then I think later on they added to around like 5,000 patients. And so they randomized all this 3,000 patients to two groups. One is PCI and another one is medical therapy group. And they followed them for 4 to 5 years. And so in the PCI group, if you see, so there's no difference in their like basic clinical characteristics. Like I'll just show a few things. The blood pressure at baseline was like 130. Sorry, I think I forgot. Can you change to the next slide, please? And the next slide. Yeah. Yeah. So if you can see, the baseline characteristics were similar in both the groups in this ischemia trial, just to show that they were like well randomized. They have features and risk factors pretty much same in each group. It's a crowded slide, obviously, because of the table. But if you can look at the systolic blood pressure, it was like 130s in both the groups, the mean value. The LDL level was like 100 and 102 in the PCI group and the medical therapy group. And the smoking population was pretty much same in both the groups. So the statin, let's look at the statin. 900 patients were on statin in the PCI group and 1,000 patients were on statin. And likewise, the number of patients on aspirin were also pretty much same. So it's a well randomized and double-blinded study, actually pretty well done in terms of like a randomized trial. The next slide, please. So in this table, you can see the number of events, the second column. They compared death and non-fatal myocardial infarction between the PCI group and the medical therapy group. You can see the hazard ratio is like 1.05, the p-value is 0.62. So they followed up for 4.6 years. The rate of events were like 19% and 18.5%, not significantly different. The one thing actually showed some difference was the revascularization. So when you look at the last row of this table, revascularization, PCI or cabbage, 228 patients, 228 events happened in PCI group, whereas in medical therapy group, 348 events happened. So you can see where that glitch comes. So the medical therapy does well compared to PCI, but then there is a high risk of getting urgent revascularization or having an event or worsening symptoms in this group with who are managed on medications. So that's the takeaway from the study. Next slide, please. So this is the Kaplan-Meier curve showing, as you can see, all the graphs, you can see the two curves are pretty much closer, and at one point it's like it's pretty much the same. So there is no significant difference in survival or event-free down the lane after starting the medical therapy, like after like 4 or 5 years or 7 years. The immediate time period, the survival or the events are better in the PCI group, but then over time, like after 2 years, the curve narrows down and there is no difference between whether someone is on medicines or whether they have had a history of PCI. So in this study, they have clearly shown with a large patient population that the medications are equivalent to like getting a stent or having a PCI done using an invasive coronary angiogram. So it is not unreasonable to attempt medications with aspirin, statins, anti-anginal therapy before rushing them to the cath lab who are having stable symptoms. But the only risk the patient should know is the immediate time period, there is some risk of getting events, more events or more worsening symptoms, which might lead to urgent revascularization. Next slide, please. This is another kind of a forest plot. You can see pretty much it's like both the groups, nothing is better than the other. And this is like a subgroup analysis. If they have diabetes, what happens in medical therapy? Like you can see the p-value is 0.3. If the rejection fraction is low or high, like less than 50%, doesn't mean less than 35%. because in this study, they excluded all the high-risk CAD patients, like whoever is having left main disease or triple vessel disease, or who are having systolic dysfunction. That high-risk patients were excluded from the study. That's another key feature of this ischemia trial. So as you can see on the right side, the p-values are not significant for any of these subgroups, like the race or history of bypass surgery or level of anginal symptoms, or whether they are smoking or not, or whether they have had a history of MI or not. Next slide, please. I think we are in the last slide now. It's a COMPASS trial. This is another trial got published in 2017, which is interesting that they used a different kind of therapy regimen. I hope you have all heard about rivaroxaban. The brand name is Xarelto. It's used for anticoagulation in patients with atrial fibrillation, DVT, or pulmonary embolism. It's a newer oral anticoagulant which inhibits factor 10A in the common pathway. So in this COMPASS trial, what they found was they used 3 different groups. One was aspirin alone, and another group, rivaroxaban. Usual dosage for anticoagulation is like 20 milligrams, but then they used 2.5 milligrams twice a day instead of 20 milligram once a day. So one group was aspirin 81 milligram with rivaroxaban 2.5 milligram twice a day, and another group was aspirin alone, and the next group was just rivaroxaban 5 milligram twice a day alone. So it's a pretty good study, well randomized, and large patient population, like 9,000 patients who have had stable coronary artery disease or peripheral arterial disease. And they followed them for 3 years to see if there is any change in the survival and events. So they found that the patients who have had who are on rivaroxaban 2.5 milligram twice a day and aspirin 81 milligram, their risk reduced by 24% compared to the other groups, mainly with the aspirin alone strategy. So the clinical impact on this is we have patients on baby aspirin alone after a heart attack 5 years ago. They are just on baby aspirin statins. They can still have heart attacks and events, but in this study, they have shown that adding rivaroxaban in a lower dose, 2.5 milligram twice a day, you can lower their risk by 24% from having a heart attack, sudden death, or a stroke, which is pretty significant. And they also showed a very good benefit for patients with peripheral arterial disease too. They didn't see any difference in survival in patients with only on rivaroxaban. They only had increased bleeding episodes from like 1 to 3%, whereas the aspirin alone actually had a higher event rate compared to this other groups. So this is not included in the guideline, not a routine practice, but after this trial came up, clinicians are using this regimen to prevent heart attacks and strokes in patients in their daily clinical practice. So that's it, I guess. It's I think it's a lot of trials. It's hard to remember, but I hope you guys can remember a few trials and you can implement in your practice in the future, and other doctors and cardiologists who are in this conference. That's it. Thank you very much. Any questions I can answer? Or
Thank you so much, Dr. Karpaya. That was really a commendable session. Over to Dr. Ravi Cherian for the moderation.
Sorry, I think I took a long time. Hope you guys are not bored in the evening time.
It was a quite good, interesting talk, and it was very useful. I think the students should have enjoyed a lot because it was so basic. You have explained well beta blockers and the other needed drugs for, especially in the cardiology. So I don't know. Questions? It was a good. Nothing. I don't have anything to ask, but it was. You
Sure.
have covered almost all the basic things for the students.
That's great. Do you guys started using any of these drugs like PCSK9 inhibitors or
No, we have not.
rivaroxaban? Instead, not yet.
The rivaroxaban we are using, but we have not started the other drugs.
Like the one used in COMPASS trial.
Yeah. We are still with the statins. I mean, rosustatin and atorvastatin. We have not used the newer drugs.
So with after the COMPASS trial, we have started using rivaroxaban in the small dose, that is 2.5 milligram twice, along with aspirin. That is, though it is stable angina, it is useful, and especially in peripheral vascular disease, where the thrombin load is very high, and anticoagulant has got a definite role in that. So that trial proved that actually anticoagulation along with the small dose of aspirin is very useful in peripheral vascular disease. That was a landmark trial.
Yeah, that's a landmark trial, and I think it's changing the practice especially outpatient.
Okay. And the talk was very useful and very informative, especially for the students and the practicing clinicians. And we thank you on behalf of Believers Church Medical College. And
thank you very much.
Dr. Karpe, the one question from our students through WhatsApp.
Okay.
Sir, can you please explain about the pharmacological stress test per se?
Sure. So pharmacological stress test is mainly for people who can't exercise, because as a clinician, we recommend exercise stress test because exercise puts you in a physiological state, creates a real demand, and increases your cardiac workload. And you can reproduce the symptoms, you can find out the functional capacity, you can identify any arrhythmias that's happening during the exercise. So that's the only downside with the pharmacological stress test. But per se, pharmacological stress test, you can do it in different ways. One is using adenosine, which is the vasodilator, also causes like heart block. You can use it in SVT, but they use like an infusion over 6 minutes. It creates a lot of symptoms at the rest. Like it can increase the heart rate, and it can cause some shortness of breath. Those are the side effects. But basically what adenosine does is it creates an environment for the heart by creating vasodilation. So what happens is when there is a vasodilation, it's kind of creating a steal phenomenon in your epicardial blood vessels. So the normal blood vessels will dilate better, stealing the blood from the, say, if your right coronary artery is 70% occluded, hypothetically, and what happens is the left anterior descending and left circumflex will dilate, and their microvasculature will dilate, and there is a steal phenomenon. The blood supply reduces to the right coronary artery territory. So it creates kind of an ischemia or a low blood supply. And then what they do is before injecting adenosine, they take a resting scan using nuclear medicine. They take pictures of your heart at various angles, process it using 3D processor or SPECT scan. And then what happens is after adenosine, 6 minutes later, this is a 6 minutes test. After 30 minutes, they do another scan using the nuclear images to see what's the difference between the perfusion between the resting and the after stress scan. So it just mimics sort of the exercise portion, but it's not like physiologically true and similar to the exercise. It just creates a local ischemia because of its effect on vasodilation and so forth. And there are, like, if patients are having a lot of symptoms with adenosine, the drug they use is regadenoson. It's a kind of a modified drug from adenosine. It has lesser side effects like bronchospasm and things like that. So those are the other pharmacological stress. And one more drug you can use is dobutamine. Dobutamine is a beta-1 selective agonist. So what it does is it increases your heart rate, increases your contractility, puts your heart under stress, creates a similar environment to exercise. And then if there is any flow limiting lesion, that portion will cause the part of the muscle will be like having any dysfunction, like systolic dysfunction, or they can have ischemic dilatation and things like that. So dobutamine you start with the 5 micrograms, go up to like 40 micrograms. And then you do, and usually it's performed with the echocardiogram, which we do as a dobutamine stress echo to see if there is any wall motion abnormalities on echo before and after dobutamine. I think someone is asking another question. Yep.
Yeah, I think the question is, sir.
It's like
Yeah, is adenosine similar to dipyridamole in terms of coronary steam?
Yeah, exactly. It's very similar to dipyridamole. Dipyridamole, only thing is it has some negative inotropic effect and things like that. So here we don't routinely use dipyridamole. We mainly use adenosine and reg adenosine. But in olden days, they were using dipyridamole stress test.
And one more question, Dr. Kalpaya.
Sure.
Again, from a student through WhatsApp. So what is the current status of evolocumab and alirocumab, which you referred to? Are you using it, or is it still in the pipeline?
We are using it. So the reason we use is like people who are having a lot of coronary obstructions and coming with recurrent chest pain and recurrent revascularization in a same vessel or same blockage. So in those patients, if their LDL is not less than 70 despite moderate or high intensity statin, mainly 40 or 80 milligram of atorvastatin or rosuvastatin, we use PCSK9 inhibitors. And the other main area where we use PCSK9 inhibitors is mainly people who can't tolerate statins. So a lot of people get this muscle pain. I think this population has a very low threshold for pain. So they can't handle more. So whenever they have muscle pain, they are very resistant to take atorvastatin. So in that case, you can't put them into PCSK9 straight away because the management or the treatment also depends on the insurance stuff. So initially we put them on alternative agents like ezetimibe, or which is called Zetia. We put them on that for a month or so, see what their LDL effect is and the effect of cholesterol control is. And then we apply or appeal to the insurance saying this patient's blood cholesterol is not controlled. So now we have to add PCSK9 inhibitors to their treatment regimen. It's because it's very expensive. It's like $5,000 per year, or it can go up to $10,000 a year. It's not affordable that easily. So we have to go through these steps to convince the insurance to pay the patients or help the patients with their treatment.
Sir,
Yes.
Yeah, sure.
Yeah, I have a doubt. Sir, in your clinical experience, how far these statins in pre-diabetic patients and on long-term treatment with statins, do they become diabetic or any, what is your experience with stat? Because so many controversy regarding the statins and hyperglycemia, no, sir? So just want to know.
Sure. It can definitely put someone into a pre-diabetic stage, like their HbA1c might go like 6.5 or 6.7, sometimes 7. But in those patients, you still recommend only like diet regimen and exercise modification. So since the statin benefits are like stupendously high, like 30% mortality benefit, you continue statins, you don't stop them, but you tell them the risk, like there are proven cases like dementia and a little bit of diabetes, but it never puts them into like a full-blown florid diabetes or DKA. And here, most of them anyway, they have type 2 diabetes or obesity, part of it with mildly elevated HbA1c, and almost most of them are on like metformin and stuff like that. In Indian population per se, I don't know. I have to look. That's one of my things I want to do, because most of the literature is mainly on Europeans or like Americans or American population. We don't have like any study mainly focusing on our Indian groups with how these drugs interplay and what happens to our metabolism and things like that. Yeah. I
Okay,
hope
sir.
that
Thank you,
answered your question.
sir. Thank you, sir.
Thank you, Dr. Karpe. Before we wind up, one final question. What is this external counter pulsation? Can you throw a little bit more light on external counter pulsation?
Yeah, sorry. Due to lack of time, I couldn't put the video or picture of it. It's quite interesting. I've seen it, but they don't routinely do it because the cost comes into play, and it has not shown to have any benefit. But it's quite interesting. What it is like it's like a blood pressure cuff. You attach a serial blood pressure cuff, like a couple of cuffs in your thighs, one in your calf muscle, both the calf muscles, and another blood pressure cuff in your arms. So what it does is you connect a EKG and you connect all this to a monitor with a console. So you can Google and find out how the picture looks if you can imagine what I'm saying. So it synchronizes with the EKG. So what happens is every diastole using the EKG, it like inflates, the cuff inflates and relaxes, cuff inflates and relaxes. So this happens in a cycle. They do a therapy for like 20 to 30 minutes on patients with refractory angina who are not improving on like Renexa or maximized medical therapy, and who are not candidates for stenting anymore or revascularization. So they lie in the bed and they connect all these cuffs, and these cuffs go on and off, like inflate, deflate, just like blood pressure. So what it happens is it creates like a improved diastolic like blood flow to all your peripheral muscles, and improves the anginal symptoms, improves the blood flow to your peripheral arteries by creating like a local vasodilatation effect. And also it improves the collateral formation. How does it do? By repeatedly inflating and deflating, you create a little bit of stress to your microvasculature, and leading to release of all these factors. Like I think mainly is VEGF, like endothelial growth factor, that gets released, and which promotes collateral formation. And these collaterals will help in reducing the ischemia or chest pains, you know. So that's the
Thank you.
explanation briefly.
Thank you. Thank you for that, Dr. Karpaya. And we are really privileged to have in our midst Professor Dr. Sudhay Kumar, one of our doyens of cardiology in Kerala, attending this session. It's a great privilege to have you, sir. If we can listen to your perspective also, we'd be really blessed. You can unmute your mic, sir.
Can you hear me now?
Yes, yes, sir.
Yeah,
We can.
hi, Sudhivamar sir.
Yeah, hi. Nice to
Hi.
see you all, and happy to hear
Yeah.
from Karpaya. Excellent
Yeah,
talk.
thank you, sir.
Okay, excellent talk. And nothing much to add, but I think you have given the lecture for the Indian population, a conservative approach, I think, because it's stressed on the medical management.
Yeah.
That's something great. Because stable ischemic heart disease, as you have pointed out rightly, and as the literature suggests, medical therapy is as equally effective as intervention. So that's the message
Yeah.
which you want to give. What I want to highlight is, in any case, risk stratification. You have highlighted that risk stratification is the most important thing. One or two points which I want to add is how long to give beta blockers. I never accept the term lifelong because science is changing. Beta blockers in 1980s, 90s, wonderful drug for treatment of hypertension, everything. Now it has taken the back seat. So lifelong approach, I think I am not in favor for any medication because modern medicine goes on changing. Regarding beta blockers, how long? Again, depends on the risk stratification. What is the clinical subset? What subset of stable ischemic heart disease? If the patient has been stable for following an ACS for 2 years, his risk comes down to a great extent. So it comes under stable ischemic heart disease without symptom of ischemia, without inducible ischemia, without LV dysfunction, and no major arrhythmias. The only thing what we need is just like primary prevention or secondary prevention. There is lifestyle modification, antiplatelet, and statin. That's the only thing which because when to stop beta blocker again is based on risk stratification. A stable patient who doesn't have any other factors, the risk of recurrence after 2 years is very low. That has been documented from the very beginning. Beta blocker heart attack trial in 1980s still goes on. Regarding the choice of beta blockers, if it is for stable ischemic heart disease with normal LV function, I may prefer metoprolol to carvedilol because it's better beta blocker in my personal experience.
Yeah.
Maybe carvedilol versus metoprolol versus bisoprolol. Like that it goes. Regarding EECP, we have in our department, in the hospital where I'm working, they have EECP. As Sir said, Dr. Kurpaya said, the only thing is the cost factor and the inconvenience for the patient. They have to come every day to the hospital, stay there. They have to have a bystander, something like 30 settings. The principle is same as Sir said, intra-aortic balloon counterpulsation, where diastolic augmentation occurs, the coronary perfusion improves, the myocardial revascularization improves, collateral forms, all the other factors, the vascular, Sir has put it very clearly. It was really a very good talk, which I enjoyed. Then regarding the skip, I'm predominantly a conservative cardiologist. Not that I am against intervention, but stable ischemic heart disease, I go for conservative management. Regarding the ischemic trial, one point which is highlighted in favor of intervention is the need for repeat revascularization. It is not the need for repeat revascularization. It is because the medical group did not have revascularization. The other group had revascularization. So if it was 13% for the intervention group versus 20% for the medical group, overall it is 120 versus 30. So for the medical group, it was not revascularization. It was the first revascularization. So at that point, I am not happy to go against ischemia trial. The need for vascularization after enrolling, you can put it like that. Because all the patients in the other group had vascularization, revascularization. Anyway, it was really wonderful talk. I enjoyed it because they have put it in a very simple manner. So keep it up. Thank you so much. Thank you, Dr. Jacob. Madam. Thank you very much for giving me the opportunity to interact with
We are
people.
so extremely happy to have you.
Oh, thank you. Thank you so much.
We are extremely happy to have you.
Thank you.
Thank you, sir. I think Dr. Karpaya did mention that currently the guidelines goes by 3 years to stop beta blockers.
For the beta blocker,
Yeah.
So as you said, it's not lifelong. I mean, medicine keeps changing, and yeah. So I think we will end on a very high note with having our beloved Sudhir Kumar sir also coming in with his perspective. And thank you so much, Dr. Karupaya, for that amazing session. Our students are really happy, and all our delegates are extremely happy with that session. And thank you for sparing your time, your precious time, to come on air and share this session with us. Really appreciate it.
It's my pleasure. It's my pleasure. I appreciate the opportunity.
Yeah.
Thank you very much. Yeah.
And I would like to take this opportunity to thank our moderators, both Dr. Leena Thomas ma'am and Dr. Ravi Cherian sir, for coming over and moderating this session. In spite of the maddening work that you have, truly appreciate the time spared, and all delegates for coming in and homing in on this session. And until we meet you with one more impactful session, we sign off from Believers Church Medical College Hospital. Thank you so much. Have a blessed weekend. Thank you.
Thank you. Thank you. Have a great weekend.